I am about to tell you something that could quite literally save your life, or the life of someone you hold dear, something I see routinely in the high-stakes environment of the operating room that your primary care doctor will almost certainly never catch, because heart failure does not start with the dramatic crushing chest pain you see in movies, and it does not announce itself with a sudden collapse on a sidewalk. Instead, it starts silently. It creeps in through the back door of your physiology, and the 5 signs I am about to share with you are not the ones you have read about on generic medical websites. These are surgeon secrets, the subtle, nuanced patterns I have learned to recognize after 2 decades of opening chests and holding failing hearts in my own hands. I am Dr. Sarah. I am a cardiac surgeon, and what I am about to reveal is not typically taught in the standard curriculum of medical school because most primary care physicians miss these signs completely, simply because they are looking for the obvious indicators like swollen ankles or severe shortness of breath. During exercise, the textbook presentations, but heart failure is smarter than that. It is a master of disguise, it mimics other conditions, and by the time the obvious signs finally appear, the damage is often irreversible. So the 5 signs I am sharing today are different. They are specific. They are the patterns that make me stop cold in the middle of a consultation and say, "We need an echocardiogram immediately." And by the end of this discussion, you will understand exactly what to watch for. You will know the physiology that your doctor does not, and you will know the one specific blood test that can detect heart failure before it destroys your life. So let us begin with sign number 5, which is that you have stopped sleeping in your bed over the past 6 months. You may have noticed a gradual shift in your sleeping habits. Perhaps you started by adding just 1 extra pillow to get comfortable. Then it became 2, and then 3. And now you find you cannot lie flat at all without feeling a sense of panic or suffocation. So you have moved to the recliner in your living room, and you tell yourself and your spouse that it is just more comfortable or that your back feels better there. But I am here to tell you it is not your back, it is your heart. This condition is called orthopnea, and it is one of the most specific signs of left-sided heart failure that exists to understand why this happens. Let me explain the mechanics of your circulation during the day. When you are upright, gravity is your friend because it pulls fluid down into your legs and away from your lungs. So your heart, even though it is weak, can manage the workload, but the moment you lie flat, gravity stops helping. And the fluid that has been pooling in your legs all day begins to redistribute and moves centrally, causing your blood volume in your chest to increase by 20 to 30% within just a few minutes now. Your failing left ventricle has a massive problem because it cannot pump that extra volume forward effectively. So the blood backs up and pulmonary venous pressure rises. Think of it exactly like water backing up in a clogged drain, and once that pressure exceeds 25 millimeters of mercury fluid, begins to leak out of your capillaries and into your alveoli, meaning your lungs start filling with water. This is pulmonary edema, and essentially, you are drowning from the inside. Your body knows this is happening even before you are consciously aware of it, because your brain senses the rising carbon dioxide levels, and you feel restless or uncomfortable, so you prop yourself up, and the moment you are upright, gravity drains that fluid back down, the pressure drops, and you can breathe again. But this happens so gradually that most people do not recognize it as a medical emergency. They think they are just getting older, or they assume the mattress is to blame, and they rationalize the 3 pillows as a simple preference. But it is not a preference. It is a physiological compensation for a failing pump. I recall a patient named Robert who was 74 and had not slept in a bed for 8 months. Because he thought he had a bad back, but I knew immediately he had a drowning heart, and his echocardiogram showed an ejection fraction of 30%, meaning his heart was only pumping 30% of the blood it should, with each beat, and every night when he tried to lie flat, his lungs filled with fluid within 10 minutes. So the critical detail here is the progression, because orthopnea does not happen overnight, it is gradual. You add 1 pillow, and a few weeks later another, and you do not connect the dots because each change feels minor, but you must step back and look at the pattern, because if you cannot lie flat anymore, or if you need 3 or more pillows, or if you have moved to a recliner, your heart is failing, and this is very different from sleep apnea, which causes snoring and pauses in breathing, whereas orthopnea causes breathlessness from fluid, and the treatment is completely different because one requires a mask, while the other requires diuretics and heart failure management. So here's what you need to understand. Your heart is a pump. And when the pump weakens, it cannot handle positional changes in blood volume, because lying flat increases preload, which is the volume of blood returning to your heart. And while a healthy heart handles this easily, a failing heart cannot. And the fluid accumulation follows a predictable pattern where first it is in your lungs at night, then it starts happening during the day, then you develop peripheral edema in your legs, and finally ascites in your abdomen, and the progression is relentless if untreated. So if you are sleeping upright, or if you cannot remember the last time you lay completely flat in bed, you need an evaluation because this is not normal aging. This is your heart telling you it cannot maintain forward flow, which brings us to the next subtle sign. You can walk across the room without any problem, and you can climb stairs, and you are not short of breath during normal activities. But the moment you bend forward to tie your shoes within 30 seconds, you are gasping for air and you have to sit up to catch your breath before you can try again. Your doctor likely thinks it is deconditioning, or maybe that you are out of shape and you might think you simply held your breath while bending, but you are both wrong, because this is bendopnea, a sign of elevated filling pressures in your heart that most physicians have never heard of. Let me explain the mechanism here. When you bend forward, several things happen simultaneously. First, your diaphragm pushes up into your chest cavity, which increases intrathoracic pressure. Imagine squeezing a balloon and watching the pressure inside spike. At the same time, bending compresses your abdomen, which squeezes blood out of your abdominal veins and sends it rushing back to your heart, so your venous return increases acutely. And in a healthy heart, this is no problem because the ventricles accommodate the extra volume and pump it forward. But in a failing heart, especially one with diastolic dysfunction where the ventricles are stiff and cannot relax properly, this sudden increase is catastrophic because the left ventricle cannot handle it, and pressure backs up immediately, causing pulmonary capillary wedge pressure to spike, which is the back pressure in your lungs, akin to water backing up in a clogged pipe. So fluid is forced out of your capillaries into your alveoli, and within seconds you are short of breath. Think of it like this. Your heart is a reservoir with limited capacity, and when you are upright, the reservoir is partially full, so you are managing, but when you bend forward, you suddenly dump extra water into an already full reservoir and it overflows. And that overflow is pulmonary edema. I had a patient, Margaret, who was 69 and could not bend down, and she thought it was just her weight. But I asked when the breathlessness happened, and she said immediately within 20 seconds of bending, which told me that is not deconditioning, that is elevated cardiac filling pressures. And her echocardiogram showed severe diastolic dysfunction, meaning her ejection fraction was normal at 60%, which is heart failure with preserved ejection fraction. So her ventricles were pumping adequately, but they were so stiff they could not relax and fill properly, meaning any increase in preload caused immediate backup into her lungs. And this is a surgeon's secret because primary care doctors rarely ask about it. They hear shortness of breath and think it is chronic, but they do not ask, does it happen specifically when you bend forward? And that specificity is everything, because bendopnea is so strongly associated with elevated filling pressures that it has been validated in multiple studies, where patients with bendopnea had a pulmonary capillary wedge pressure averaging 25 millimeters of mercury, which is severely elevated. So here's the test you can do at home. Sit in a chair and bend forward at the waist as if you are tying your shoes, and stay bent for 30 seconds if you become short of breath within that time, and the breathlessness resolves when you sit back up. That is bendopnea, and you need a cardiac evaluation, because this is not anxiety, since anxiety does not follow mechanical patterns. This is pure physics, where increased intrathoracic pressure plus increased venous return equals acute elevation in left atrial pressure, and the weak heart cannot compensate the reason. This matters is that bendopnea predicts poor outcomes and patients with bendopnea have significantly higher rates of hospitalization and mortality from heart failure, so it is a marker of advanced disease even when other symptoms are mild, and if you can walk fine, but you cannot bend forward without gasping. Your heart is failing, so do not let a doctor dismiss it and demand an echocardiogram. Now consider the third sign. You wake up 3 times every night to urinate, and you assume it is your prostate. So you see a urologist and they prescribe medication, but it does not help, and you are still getting up 3, 4, or 5 times per night, yet no one checks your heart. This is nocturia, and in many cases, it is not your bladder. It is your heart, clearing the fluid that accumulated in your legs all day. Here is how it works during the day. When you are upright, your heart is weak, so cardiac output is reduced, and blood flow to your kidneys drops. Your kidneys sense this and panic, interpreting it as a crisis, so they hold on to every drop of sodium and water. They can, meaning your urine output during the day is minimal, but all that fluid has to go somewhere, so it pools in your legs where gravity pulls it down. And by evening, your ankles are swollen and your legs feel heavy, and you have gained 3 pounds of water weight since morning. Then you lie down to sleep, and gravity stops pulling the fluid into your legs, so that fluid redistributes and re-enters your circulation. Suddenly, your blood volume increases, and your kidneys see this increase and think, finally, we have enough fluid. We can make urine now. So your kidneys start working and they produce urine. Lots of it, meaning all that fluid that was in your legs during the day is now being filtered by your kidneys at night. So you wake up every 2 hours needing to urinate. And this is your heart's daily cycle of failure and compensation, because during the day, your weak heart cannot perfuse your kidneys adequately. But at night, redistribution allows your kidneys to catch up. Think of it like A reservoir, where during the day water flows in slowly because the pump is weak, so the reservoir overfills and spills into the surrounding area, which represents your legs. But at night, you open a valve and all that excess water drains through at once. I remember James, who was 71 and was getting up 5 times per night, and his urologist did a full workup finding everything normal. But I asked one question: do your legs swell during the day? And he said, yes, my socks leave marks. And that is the connection. Peripheral edema during the day plus nocturia at night equals heart failure. His echocardiogram showed biventricular dysfunction, meaning both sides of his heart were failing. Right-sided failure caused the leg swelling, and left-sided failure reduced daytime kidney perfusion, but at night, lying flat improved cardiac output just enough for his kidneys to work. So here is the specific pattern to watch for if you urinate more at night than during the day, and if the volume at night is large. And if this correlates with daytime leg swelling that improves by morning, it is cardiac nocturia, which is different from an overactive bladder that causes frequent small voids throughout the day and night, whereas cardiac nocturia causes large voids specifically at night with reduced daytime output. The mechanism is pure renal physiology because your kidneys require adequate perfusion pressure to make urine. And when your heart cannot generate that pressure during the day, your kidneys shut down and wait until nighttime redistribution improves perfusion, then they work overtime. This pattern is so reliable that cardiologists use it diagnostically. So if you tell me you wake up 3 or more times per night to urinate and your legs swell during the day, I am ordering an echocardiogram before I send you to a urologist, because the reason this matters is that nocturia from heart failure will not respond to prostate medications or bladder medications since you are treating the wrong organ. The bladder is fine, the prostate is fine, the heart is the problem. So if you are getting up multiple times per night to urinate, especially if you produce large volumes each time, and especially if you have any daytime leg swelling demand, a cardiac evaluation, get a BNP blood test, check your ejection fraction, and rule out heart failure before spending months on treatments that will not work. Now let us talk about the fourth sign, which is a paradoxical one. You have no appetite and you feel full after just 2 bites, meaning you are eating less than half of what you used to. Yet somehow the scale keeps going up and you have gained 5 pounds in 2 weeks despite barely eating. This is biologically impossible if we are talking about fat, because fat requires calories and you are not consuming calories. So where is the weight coming from? It is not fat. It is fluid. And the combination of poor appetite with weight gain is one of the most specific signs of advanced heart failure. That exists here is the mechanism. When your right heart fails, blood backs up into your liver and intestines, creating hepatic congestion and mesenteric edema. Your liver swells and the capsule stretches, causing a dull ache in your right upper abdomen, while your intestinal walls become edematous, meaning they are swollen with fluid. This has 2 effects. First, the swollen gut wall activates stretch receptors that send signals to your brain saying you are full, even though your stomach is empty, which is early satiety. Second, the edematous gut wall cannot absorb nutrients properly, so food sits undigested, causing nausea and bloating, leading you to lose your appetite completely, so you stop eating, and your caloric intake drops to 800 or 600 or 400 calories per day. And by all logic, you should be losing weight rapidly, but you are not. You are gaining weight because your failing heart has activated something called the renin-angiotensin-aldosterone system. Let me explain this because it is the key to understanding why heart failure causes fluid retention. Your heart's job is to maintain blood pressure and ensure adequate blood flow to every organ. So when your heart starts to fail, cardiac output drops and less blood reaches your kidneys. Your kidneys have sensors that detect this reduced blood flow, and they interpret it as a life-threatening emergency, thinking you are bleeding out or severely dehydrated. So they activate this system, which does 3 things. First, it constricts your blood vessels to raise blood pressure, like pinching a garden hose to increase water pressure. Second, it signals your adrenal glands to release aldosterone, a hormone that makes your kidneys hold on to sodium. And third, when you retain sodium, water follows. So your body holds on to every ounce of fluid. This compensation mechanism made sense evolutionarily, because if you were bleeding or truly dehydrated, this could save your life, but in heart failure, it is catastrophic, because your heart is already struggling, and now you are adding liters of extra fluid to a system that cannot handle what it already has. The result is rapid weight gain, not from calories but from water, creating a paradox where you are starving and drowning simultaneously, leading to muscle wasting from malnutrition and fluid accumulation from heart failure, meaning the scale goes up even as your body wastes away. And this is cardiac cachexia, a late sign that indicates heart failure is advanced. David was 73 and lost interest in food over 3 months and could not finish a meal, but he had gained 12 pounds and physical exam told the story his abdomen was distended and fluid wave, positive meaning when you push on one side of the abdomen, you feel fluid shift to the other like water in a balloon. He had ascites comprising 3 liters of fluid in his abdominal cavity, and his legs were massively swollen with another 2 liters while his jugular veins were distended, showing blood backing up all the way to his neck. Echocardiogram showed severe biventricular failure with significant tricuspid regurgitation, meaning his right ventricle was so weak that blood was leaking backward through the tricuspid valve with every heartbeat, creating a cycle where poor forward flow caused congestion and congestion worsened the regurgitation. Here is what most doctors miss. They see weight gain and assume overeating, so they recommend diet and exercise, completely missing that the patient has no appetite and can barely eat because they never ask about early satiety or nausea. But if you ask the right questions, the pattern is obvious. How much can you eat at one meal, 2 bites? Do you feel full immediately? Yes. Is your abdomen bloated? Yes. Are you gaining weight? Yes. That combination points directly to cardiac congestion. The physiology here is critical because your liver needs blood flow to function. And when blood backs up into your liver, hepatocytes cannot work properly, so they cannot synthesize proteins or metabolize toxins, leading to hypoalbuminemia or low albumin levels. And albumin creates oncotic pressure, which is like a magnet that holds fluid inside your blood vessels. So when albumin drops, that magnet weakens and fluid leaks out even more easily, worsening the edema. Your intestines also need blood flow to absorb nutrients. And when the mesenteric veins are congested, the gut wall swells, so absorption fails, meaning even the small amount of food you are eating is not being utilized, so you are malnourished despite eating. Which is why cardiac cachexia has such a poor prognosis. You are losing muscle mass from starvation, and your heart muscle is part of that loss, meaning a starving heart gets weaker and the cycle becomes irreversible if you are experiencing loss of appetite with weight gain, or if you feel full after just a few bites, or if your abdomen is bloated, you need emergency evaluation, because this is not a diet issue. This is advanced heart failure. So get to a hospital, get a BNP, get an echocardiogram, because this combination predicts high mortality without intervention. Finally, consider the 5th sign: you eat lunch, and within 30 minutes, you feel dizzy and lightheaded, while your thinking becomes foggy and you cannot concentrate. So you assume your blood sugar dropped. You check it, and it is normal. So you think maybe you ate too much, but it is not your blood sugar, and it is not overeating. It is your heart. What you are experiencing is postprandial hypoperfusion, meaning blood is rushing to your gut to digest food, and your weak heart cannot supply both your gut and your brain simultaneously. So your brain loses and you become hypoxic. Here is the mechanism: when you eat, especially a large meal, your body needs to divert massive amounts of blood to your gastrointestinal system. Because digestion is metabolically expensive and your gut needs oxygen to break down food, absorb nutrients, and move everything through. In a healthy person, this is no problem because your heart increases cardiac output by 20 to 30% after a meal, so blood flow to the gut increases and blood flow to the brain stays stable. But if your heart is failing, and if it is already operating at maximum capacity just to maintain baseline perfusion, it cannot increase output. So it has to make a choice, gut or brain, and it chooses gut because digestion is immediate and necessary. So the brain gets less blood, and your brain is the most oxygen-sensitive organ in your body, meaning it cannot store oxygen and needs constant delivery. So when cerebral perfusion drops, even 10% symptoms appear immediately, including dizziness, lightheadedness, confusion, difficulty thinking, and visual changes. This is postprandial hypoperfusion syndrome, a sign of severely reduced cardiac reserve. Think of your heart as a limited power supply where you have 100 watts total, and at rest your brain uses 40 watts, your gut uses 20, and everything else uses 40. So you are balanced, but after a meal, your gut needs 60 watts and you only have 100 total. So something has to lose power, and it is your brain which drops to 20 watts, causing the lights to dim. I recall Eleanor, who was 80, and became confused within 20 minutes of every lunch and could not remember conversations or got disoriented, so her family thought dementia, but I noticed the pattern only happened after meals and between meals. Her cognition was normal, which is not Alzheimer's, because Alzheimer's does not follow meal patterns. Her echocardiogram showed an ejection fraction of 28%, meaning her heart was so weak that digestion caused her brain to become hypoxic. So within 30 minutes of eating, her cerebral blood flow dropped 25%, and her neurons could not function, making her appear demented. We started heart failure medications, including ACE inhibitors, beta blockers, and diuretics, and Within 2 weeks, her postprandial confusion resolved, and she could eat without cognitive impairment, meaning she was not demented, she was hypoperfused. Here is what primary care doctors miss. They see confusion in an elderly patient and assume it is neurological, so they order a brain MRI and diagnose dementia, never asking, does this happen specifically after meals? But that question changes everything, because if the confusion is postprandial, it is not dementia, it is cardiac. The mechanism is pure hemodynamics because splanchnic blood flow, which is blood flow to your abdominal organs, increases by 30 to 40% after a meal, and in heart failure patients with fixed cardiac output, this increase must come from somewhere. So it comes from the brain, and periphery studies using transcranial Doppler have shown that cerebral blood flow velocity decreases significantly in heart failure patients after meals, and the decrease correlates with meal size, meaning a bigger meal leads to a bigger drop in cerebral perfusion, which is why some heart failure patients stop eating large meals and intuitively learn that eating makes them feel terrible, so they start eating tiny portions multiple times per day instead of 3 large meals, which is adaptive because smaller meals require less blood diversion, so the brain does not get starved as severely. If you experience dizziness, confusion, or lightheadedness, specifically after eating, especially after large meals, this is a red flag for advanced heart failure, indicating your cardiac reserve is so depleted that your heart cannot handle the metabolic demands of digestion and cerebral perfusion simultaneously. This is different from reactive hypoglycemia, where blood sugar drops after eating. So check your blood sugar when symptoms occur, and if it is normal, it is not glucose, it is perfusion. It is also different from orthostatic hypotension, where blood pressure drops when you stand because postprandial hypoperfusion happens while you are sitting, so you do not have to change position. Just the act of eating triggers it. If this is happening to you, you need urgent evaluation because postprandial symptoms indicate your heart is operating on the edge, and any additional stress could push you into acute heart failure. So we have covered 5 signs that primary care doctors miss: the recliner chair sign from orthopnea, the shoelace sign from bendopnea, the bathroom run sign from nocturia, the appetite paradox from cardiac cachexia, and the after-lunch fog from postprandial hypoperfusion. These are not the obvious presentations of heart failure. They are the subtle ones, the patterns that require surgical experience to recognize, and the signs that tell me a heart is failing before the textbook symptoms appear. If you are experiencing any of these, you need one specific blood test called BNP or B-type natriuretic peptide. When your heart muscle is stretched from increased pressure or volume, your ventricles release BNP into your bloodstream, which is a hormone that tries to help by causing vasodilation and promoting sodium excretion, representing your body, attempting to reduce the workload on your failing heart. The level of BNP in your blood correlates directly with the severity of heart failure, where normal is under 100 picograms per milliliter, and if it is elevated, your heart is under strain. BNP is sensitive and catches heart failure early. And more importantly, if your BNP is normal, heart failure is unlikely, giving it a high negative predictive value, meaning a normal BNP effectively rules out heart failure as the cause of your symptoms. This test costs less than $50 and requires 1 blood draw with results in hours, so it can save your life. Go to your doctor and say this: I would like my BNP checked because I am having symptoms that concern me for heart failure, and I need to rule it out. Most doctors will order it immediately if your BNP is elevated. Demand an echocardiogram because the echo will measure your ejection fraction, evaluate your valves, assess your diastolic function, and show whether your chambers are dilated, telling you definitively what is wrong with your heart. From there, treatment is straightforward, involving diuretics to remove fluidase inhibitors, or ARBs to reduce afterload, which is the resistance your heart pumps against beta blockers to improve contractility and reduce remodeling, and sometimes aldosterone antagonists if you have advanced disease, but the key is early detection because heart failure caught early is manageable and you can live decades with good quality of life, whereas heart failure caught late has a 5-year mortality rate worse than most cancers. So these 5 signs are your early warning system, and you must pay attention to them. Before I close, I want to tell you about something I am building called Senior Health Life. Daily, a community where I share detailed medical information that goes beyond what I can cover in these videos. I am finishing an ebook specifically about cardiovascular health for seniors, covering everything from how to interpret your lab results to what questions to ask your cardiologist and what symptoms mean emergency versus watch and wait, along with medication side effects your doctor might not mention, and diet and lifestyle modifications that actually work. This ebook will be available exclusively to members of Senior Health Life Daily. So to join, click the link in the description and enter your email, and you will be the first to know when it launches. I do not sell anything, and I do not run ads. This is just a way for me to share more detailed information with people who want to take control of their heart health. So join the community and be part of something that could genuinely save your life or the life of someone you love today. I shared 5 signs of heart failure that your primary care doctor does not know to look for, including the recliner chair sign from Orthopnea, the shoelace sign from Bendopnea, the bathroom run sign from Nocturia, the appetite paradox from cardiac cachexia, and the after lunch fog from postprandial hypoperfusion. These are surgeon secrets patterns I have learned from holding failing hearts in my hands and seeing what happens to the rest of the body when the pump fails. So if you are experiencing any of these symptoms, advocate for yourself, request a BNP test, get an echocardiogram, and do not accept that it is just aging as an explanation, because early detection saves lives, but you have to know what to look for. Share this video with anyone over 60, as these signs could save someone's life, and comment below if any of these resonate with you, because your experience might help someone else recognize their own warning signs. Subscribe if you have not already, because I am Dr. Syra, and I am committed to sharing the medical knowledge that could keep you out of my operating room. Take care of your heart.